I think we can now move to the 5 questions, and I would like each of you to tackle one of them. So I think we can start with Batia, and then we move on. And so just with the idea that if we can, keep brief, then the idea is that in the round table that we will create, appropriate the space, each of our panelists will then dig into and deepen more each of these topics.
Yeah. So in Julia's, when she introduced, one of the things that she highlighted was really relating how healthcare organizations are high reliability organizations. And there's a very high cost to mistakes and omissions. So this is not a situation where you can make a wrong decision with giving someone credit who doesn't deserve it, or underpricing insurance, or making the wrong recommendation on YouTube or Netflix. But when you make a mistake in healthcare, there are lives at stake. And it is, Julia also highlighted, this is a heavily regulated industry. So there's FDA, there's malpractice law, there's the American Medical Association. There are these factors that I think create this high reliability organization, which means that in healthcare, more so than in many other applications of AI at work, we are going to see for a much longer period of time that there is going to be augmentation, collaboration between humans and AI, rather than the automation or replacement of work, because you ultimately need someone with a license to sign off on something. And so that is really part of the opportunity with this first question. There are also this high reliability organization emphasis means that sensitivity, not specificity, matters more. Some of you guys are sort of thinking about the sensitivity, specificity, all that area under the curve, all that garbage. But so the thing is that in healthcare, the true positivity rate of many of the true positive, we're talking about diseases that are occurring, 1% of the time or less. So that means that a really good model is right 30% of the, that is a fantastic model, a model that's right 30% of the time. That also means that there's always going to be the need for expertise to make that judgment, because the model is not going to be right. Really can't do all of that. I think that there are some really interesting questions that presents for how do humans and AI make decisions differently? And one of them is, I'll just give you some examples. One example is that providers, and I think that this is Samar kind of mentioned something like this, that providers humans succumb to the availability heuristic. Many of you, and the base rate fallacy, which is a flip side of the availability heuristic. This might be familiar to some of you, maybe not all. I think of that as one of the things Stalin famously said is that a single death is a tragedy, a million deaths is a statistic, and humans pay attention to the anecdotes that influences our decision making. Well, doctors have to focus on the anecdote is the patient in front of them, and they have to understand all the situations related to that patient who may or may not be an exception to the rule. And the AI is focused on the base rates. And so there's a complete disconnect between what the AI focuses on, what the human focuses on. And that's where the opportunity for collaboration and sort of complementarity, can come in. So so the general issue is, if we understand how humans and machines make decisions differently, we can look for opportunities for complementarity. And so here's one example. A second issue is that providers are trained to focus on causal attributions. People think in terms of narratives. They think in terms of A caused B. They want a story. AI is designed to identify leading indicators. Leading indicators are not necessarily causal factors. And so this complementarity of being able to see the connection, what are the causals, what are the leading indicators, and what's the connection between them, is also this opportunity for complementarity that I think we are going to help to see what that fun. I mean, these are just a couple of examples where I think what you'll see is this development of roles, differential development of roles that will help, where the human roles are going to change somewhat in order to adapt to the things that the machine can do better. And we need the machines because right now in healthcare, less than 50% of evidence-based best practice is actually being implemented. So there's a real opportunity for the base rate information to get integrated in because that is largely being omitted. I think just one last example, which is that, so as AI does not transfer well. It doesn't transfer well across individuals, especially when they are from different professional jurisdictions. It doesn't transfer well across teams, and it doesn't transfer well across organizations. And the problem with that, when we think about a drug, there's a difference between efficacy and effectiveness. Drug efficacy is how well does it work under ideal conditions. Drug effectiveness is how well does it work in real life. We have a problem with AI efficacy because already the AI is, in healthcare is being developed and doesn't work well outside of its training data. So that's part of the problem. That problem is rapidly being addressed. Not as rapidly as they would let you believe, but it is definitely being addressed. The problem that we as organizational scholars can help to address is the effectiveness problem, which is much more intractable. And that requires understanding what are the factors that are going to be the challenges as AI transfers across individuals, teams and organizations. And that means the individual factors like differential preferences, roles, levels of experience, types of training are going to be barriers in transferring AI. At the team level, what we've been finding is interdependencies across roles and communication patterns seem to be the things that, it'll work in this place because there are all the things that Samar has found in his previous published work, as well as things like emotion regulation processes that we are finding are kind of in the way with how AI transfers across teams. And then in terms of organizational factors, so organizations differ in their systems for feeding accurate and timely information into AI models, for correcting that data. And remember, AI models are only as good as the data that they get. And that is a real problem in healthcare. For economic incentives, which differ across organizations, efficiency, billing, whether you can bill for it or not. So these are some of the places that I think we're seeing, challenges of how do we divide the work between humans and machines, and whether AI will get taken up at these different levels and across organizations.